Dr. Cheng, are you here? Hmm.
The teacher is here, but he cannot use his microphone.
Yeah. I think Dr. Munira, I think we start first while waiting for Dr. Cheng to uh do the repair. Come up with the microphone.
Okay, sure.
Okay. Good afternoon, everyone. Welcome to our weekly webinar. This month is Infectious Disease Month. This is the third week of our ID month, and our topic for today is malaria. And we would like to invite Dr. Munira as our speaker from ID physician from Hospital Tengku Ampuan Afsan Pahang as our speaker, and our chairperson is Dr. Cheng Juti, is a infectious disease consultant from Hospital Raja Permaisuri Bainun Ipoh Perak. Without further ado, let's welcome Dr. Munira to present this webinar.
Hello, thank you. Thank you for the introduction. I'm Dr. Munira from HTA Kuantan. So I've been given this chance to talk about malaria, which is a parasitic vector-borne disease. Okay. So so this is the outline of my talk. At the end of the talk, I'll just share a case as well. Okay, so as we know, malaria is a vector-borne disease. It's transmitted by Anopheline mosquito. So there are actually 4 human malaria parasites, which is Plasmodium falciparum, Vivax ovale, and malaria. But there's another one, which is a zoonotic a simian parasite, meaning it comes from monkey mainly, which is Plasmodium knowlesi, which is the most common malaria infection in Malaysia. So this is zoonotic, meaning there is no, as far as we know, there is no human to human transmission as far as we know so far. Okay, so Plasmodium falciparum is the one that caused the vast majority of severe disease. Okay, but sometimes knowlesi as well as vivax can also cause severe disease. Okay. Right. So incubation period for the parasites, basically the moment after you are bitten by the mosquito to the time that you manifest the disease. For falciparum is mainly 7 to 14 days. Vivax about 12 to 17 days. Ovali is about 15 to 18 days. For malaria, Plasmodium malaria is longer, about 18 to 14 days. But we have to remember that Vivax and Ovali, they remain dormant in the liver. We call it a liver hypnozoid, so they can relapse months or years later due to reactivation. And Plasmodium malaria, there is no hypnozoid, but they may persist in the blood at low level for many years. Okay, so this is bilangan kes malaria in Malaysia lah. So from up to 1980, it was actually the phase of eradicating malaria, and then after that it was malaria control, and then currently we are in the phase of eliminating malaria. So this is the incident rate of incident rate of malaria in Malaysia. So you can see the state that has highest malaria is Sabah, followed by Sarawak, and then Kelantan and Pahang. Okay, so Pahang is basically in top 4 in Malaysia. Okay, so this is case mengikut klasifikasi dan kematian. If you see the one in green is actually zoonotic. So since 2008 until now, we're getting more and more zoonotic malaria, which is Plasmodium knowlesi. But the good thing is, the indigenous human malaria, meaning the malaria that transmit from human to human too, the last case we had was in 2017. After that, we have no more indigenous human malaria, but we do have human malaria that is imported. You see the yellow one? This is imported one, meaning they are coming not from Malaysia, they are coming from outside Malaysia. Okay, and you can also see actually the death number, if you compare to year 2000, is much, much lower now. Okay, so our malaria in Malaysia is mainly human malaria is imported, and mainly we have only zoonotic malaria. And this is the number of cases according to the Plasmodium species. This is Peninsular Malaysia. You can see, of course, lately is mainly knowlesi, but we also have imported vivax cases. Also in Sabah and Sarawak, you can see it's mainly knowlesi. Okay, so since the main malaria parasite in Malaysia is zoonotic, so it's important to know that it's actually coming from simian, meaning it's coming from monkeys now. This is the long-tailed macaque. This is the pigtail, and this is banded leaf monkey that actually may become the host of knowlesi. And then the vector is Anopheles mosquito, and then they are mainly found in deep jungle or forested area in Malaysia. So that's why in Malaysia, the main area that have risk of malaria is if you visit all the jungle or deep forested area. So if you just go to KL or Penang or Johor, probably no, it's basically not a risk factor. Okay, Plasmodium knowlesi has daily asexual cycle. So it basically result in rapid replication rate and high parasite level. So this actually can lead to fulminant disease, similar to Plasmodium falciparum. But Plasmodium falciparum can cause coma, but coma or cerebral malaria doesn't usually happen in Knowlesi. That's the only good thing. We rarely see coma in Plasmodium knowlesi. Okay, so this is life cycle. It's quite interesting to know that basically this parasite, they have two life cycle, either sexual or asexual. So the sexual is basically inside the mosquito, female mosquito, yeah, specifically. Asexual is inside the human body. So when the female mosquito bites human host, they actually inject the sporozoid into our bloodstream, and then this sporozoid will go into the liver and they remain as a liver schizon. And then this schizon will eventually rupture and they will release merozoite into the bloodstream. And then this merozoite actually invades the red blood cell. And then some go into tropozoite ring stage and then mature tropozoite. And some actually go into sexual phase, which is gametocyte. This gametocyte has longer half-life compared to schizon. So the schizon will rupture and the cycle continues, whereas the gametocyte, it will be taken by mosquito in a blood meal, and then develop into zygote, and this zygote become oocyst, and oocysts are ruptured and to release sporozoid, and the sporozoid will be released into human when the mosquito take a blood meal. So that is basically the life cycle of parasite. Okay, so next important thing is what are the clinical features of malaria? Okay, especially Plasmodium falciparum, if untreated, it will become rapidly life-threatening, especially in children and also non-immune adult. What does it mean by non-immune adult? Adults that have never had malaria before and they don't live in endemic area. But fortunately, ovale and malaria, Plasmodium malaria, are less likely to progress to severe disease. But vivax mostly are mild, but sometimes vivax can cause severe disease as well. So Plasmodium falciparum, they usually have high blood parasite density, and they can sequestration in microvasculature, which is a hallmark you find in cerebral malaria. So in acute malaria, usually they will start with a prodrome of tiredness, just aching, and then they will have a paroxysm of dramatic rigor, which we call a cold stage, and then it goes into the hot stage when they have a high temperature of more than 40. At this time, they become restless, they can have vomiting, and then eventually they go into sweating stage when actually the temperature drop and they feel better and they actually sleep. So this paroxysm can actually last from 6 to 10 hours. Okay. But in vivax and ovale, they may have asymptomatic period of 38 to 40 hours when we call tertian fever, or in malaria infection, they may have longer asymptomatic period, for example, 62 to 66 hours in Plasmodium malaria. So they may have period that they feel well. Okay, so in Plasmodium falciparum, the fever is unpredictable. It can be continuous fever the whole day. And sometimes they may come with a non-specific symptoms such as just headache, cough, feeling myalgic, have some diarrhea, or just mild jaundice. But if you find lymphadenopathy, pharyngitis, rash, these are actually not a symptom of malaria, and you have to find alternative diagnosis. So in children, it may be non-specific symptoms, but the progression is faster in children. Jaundice, pulmonary edema, and renal failure are more common in adult. Okay, so the biochemical features are mainly they have anemia. In children especially, they can come with severe anemia. They have thrombocytopenia. They may become hypoglycemic in severe cases. They may have high bilirubin or a bit of transaminitis, AKI, and acidosis. Okay, so this is the classification of severe malaria. So if you have one of the following, it's considered a severe malaria and the treatment is different. So what are the characteristics? If they have reduced conscious level, if they have prostration, meaning generalized weakness that they can't even stand or sit, or they have seizures, they have acidotic breathing, if they have any pulmonary edema or ARDS, any shock, any AKI, any jaundice or other organ dysfunction, bleeding, low sugar, acidosis, severe anemia, or they have hemoglobinuria, high parasite count, meaning in a low transmission area, anything more than 2% of parasitemia is considered severe. High lactate, renal impairment, or pulmonary edema. So all these show that this patient has severe malaria. So in falciparum malaria, you can see in children, they mainly have anemia. Yeah, children, they have anemia, or they can have quite bad acidosis, coma or cerebral malaria, and they may have a lot of convulsion. But in adult, it's mainly they can have jaundice and renal failure. But as the age advance, they may have more shock, acidosis, and cerebral malaria. Okay. So cerebral malaria is basically common in it doesn't happen in Sulawesi as I said before, but it's common in Plasmodium falciparum, uh, uh, um, which is a human malaria. Okay, so the mortality is quite high, 10 to 20 in adult. In children, it can be up to 40%. It can happen in non-immune adult or children, meaning people who've never had malaria before, never lived in malaria endemic area before, and then they get malaria, they can get cerebral malaria. And then neck rigidity and photophobia are not usually seen, and clinic sign is usually negative. So they may have one of the diffuse cerebral dysfunction with coma or convulsion. 50% of them have convulsion, or they have focal neurological sign or brainstem sign. 15% have retinal hemorrhages, and quite a lot, 5% of them have neurological complications, and higher, about 10% of children will have neurological sequelae when they survive from cerebral malaria. Okay, so respiratory distress is also common in severe malaria. Why they have respiratory distress? It can be because of respiratory compensation for acidosis or ARDS due to direct alveolar capillary damage by parasite, or it's actually worsened, which is actually worsened by hypoalbuminemia or giving too much fluid, or they can have air hunger due to severe anemia, or they have respiratory bacterial infection, or we call it secondary infection due to immunosuppression caused by malaria. And also anemia is common. They are usually normocytic. Severe anemia with HB less than 5, with parasite count more than 10,000 is actually a common presentation in African children. So hyperparasitemia and or G6PD deficiency can lead to massive intravascular hemolysis in malaria. And jaundice, in malaria, there are several mechanisms why they have jaundice. It can be due to hemolysis or hepatocellular damage, or due to cholestasis. It is basically both conjugated and unconjugated hyperbilirubinemia, and usually it's more than 50. But in children, jaundice is rare. So renal involvement is common. Is basically both pre-renal and renal cause. So pre-renal is due to hypovolemia and shock. Renal cause is basically due to immune deposit causing glomerulonephritis, paroxysm causing acute tubular necrosis, or acute interstitial nephritis. So other causes would be hemolysis, rhabdomyolysis, hepatorenal syndrome, are also causes of renal impairment. So renal failure, especially if they're anuric in malaria, they have very poor prognosis. 45% die unless they have acute dialysis or hemofiltration. And if they get dialysis, they may get a good recovery within 1 to 2 weeks. Okay, so black water fever is something that we always hear. What is black water fever? Is synonym to malaria because it's due to massive hemoglobinuria when the urine become very dark, like Coca-Cola. You see this one, dark urine. So the urine when we test is positive for blood due to hemoglobin, but when you look at the microscope, you can't see any RBC. It's basically due to hemoglobin in the urine. So in some cases, in the past, they used to use quinine for treatment for malaria. So quinine can cause hyperinsulinemia and hypoinsulinemia. Sorry, and also it can cause hemoglobinuria. Or when you give primaquine prophylaxis, which is an oxidant drug, it can also cause this black water fever. This is more common in G6PD or other enzyme deficiency. Okay, so hypoglycemia, as I said earlier, it can be missed in patient, especially if they come with reduced conscious level. It's usually due to, it can be few factors. First is because the liver function is reduced or increased demand of hypercatabolic state and infecting parasite. So quinine can cause high insulin and hypoglycemia. We don't use quinine in Malaysia, but there are some places still using quinine, IV quinine for severe malaria. So these are the side effects they get. And hypoglycemia actually indicates poor prognosis and is actually a risk factor for neurological complications. So in adult, the hepatic glycogen store lasts about 2 days, but in children is less. It's about 12 hours. So hypoglycemia is more common in children than adult. So ARDS is a common thing, a complication that can happen, which is not common, but is something that can happen in severe malaria. Uh, 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 Usually occurs in non-immune adult, but it's rare in semi-immune. Why is rare in semi-immune? Because they have some sort of immunity because they had malaria before. So, but when we have ARDS, it's very high mortality. Half of them die. It can even occur even when the patient actually seem to be improving. Okay, it's usually it can be exacerbated by excessive fluid replacement. So, judicious use of fluid in malaria is very important. And predisposing causes of RDS include high parasite count, if they have renal failure, or if they are pregnant. So if they are pregnant, they can have ARDS right after they deliver. Okay. So hypoxia may lead to convulsion and death within few hours. So it's a grave complication of malaria. So next is hyperparasitemia. What does it mean by hyperparasitemia? Okay, it depends on where you live and the type of parasite. So if it's an endemic area, meaning if, for example, in Africa, when they have a lot of human to human transmission and a lot of people live with malaria parasite without any symptom. So for them, anything more than 5% of RBC infected is considered hyperparasitemia. But for us, anything more than 2% of RBC infected, meaning more than 100,000 of parasite of microliter blood, is considered severe. But if it's Plasmodium knowlesi, you have to remember more than 20,000 parasite count per microliter blood is also already considered severe or hyperparasite. Okay. So anything more than 10% parasite count is carries half of them will die, especially in non-immune individual. So secondary infection is also common in severe malaria. So septicemia, pneumonia, UTI are common, and gram-negative septicemia can occur without any focus of infection, especially in semi-immune children. So that's why in severe malaria, they actually suggest to cover with antibiotics until you are sure there is no secondary infection. Okay, so what are the indicators of poor prognosis in malaria? Is basically when they are agitated, when they are hyperventilating, when they have hypothermia, coma, convulsion, bleeding, or anuria or shock. Lab finding of hyperparasitemia, or a lot of or more than 20% of parasite in late stages. Late stages meaning trophozoite and schizon, meaning they are actually severe. And then or they have more than 5% blood film showing neutrophils or visible pigment. or they have hypoglycemia, high lactate, acidosis. All these things are indicating that they have poor prognosis. Okay, there's something called chronic malaria, which probably some of us have never heard, but there is a condition called chronic malaria when they have persistence of low level of parasitemia, especially in semi-immune people. So this is quite common in places like in Africa, where they have a parasite living in their body at certain level, but it's not high enough to cause any symptoms in them. So it's common in endemic area, and they may have recurrent acute attack of malaria, causing anemia, hepatosplenomegaly, diarrhea, or loss of weight. This condition can resolve with partial immunity, or it may progress with causing secondary complications. Okay, hyperreactive malarial splenomegaly is also called tropical splenomegaly syndrome. This can follow after recurrent infection of malaria. They have massive spleen. They have profound anemia. They may have secondary bacterial infection, fever, and sometimes they are jaundice. So they also have hypersplenism with pancytopenia, hypergammaglobulinemia, and lymphocytic infiltrate in the liver. So they have high serum IgM level. But the funny thing is, you may actually never find the parasite in their body. But these people actually respond to prolonged course of antimalarial drugs. Okay, pregnancy is also an important thing that we should know in malaria. So in areas of high stable transmission, a lot of them are actually asymptomatic, meaning they are pregnant, they have the parasite in their blood, they're asymptomatic. But they may have anemia, and then they may be complicated with low birth weight, increased infant morbidity and mortality. But in area with unstable transmission, meaning sometimes there is transmission, sometimes there is no. If they are pregnant and they have malaria, usually they have severe malaria. Okay, and they have anemia, low blood sugar, and APO. They may also have fetal distress, premature labor, stillbirth, and low birth weight. So in severe malaria, fetal death is common. In high transmission area, more than 50% of the babies are born with congenital malaria, but they are rarely symptomatic when they are born. Okay, that's why they should be monitored for congenital malaria. Okay, then the next important thing, how you diagnose malaria. So in all cases of malaria, they all should be diagnosed with microscopy of peripheral blood film. Okay, in certain situation, in certain place, they use rapid diagnostic test. I will speak about rapid diagnostic test later. Okay, but presumptive treatment without a diagnosis should be avoided wherever possible. Meaning, empirical anti-malaria, they are not something that is not encouraged. Okay, unless you have a very strong suspicion. I will tell you about a story about empirical artesunate later on. Okay, so in high transmission area where asymptomatic parasitemia is common, overdiagnosis of malaria is a major problem. For example, in Africa, for example, a lot of them actually carry the parasite without any symptom, and then they come with some illness. For example, they get COVID, and then the BFMP or RDT was done and noted positive, and they are treated for the malaria. But actually, the main reason why they come is not because of malaria, but it's just overdiagnosed. So thankfully in Malaysia, we don't have this problem, but it's a big problem in other countries lah. Okay, so when you suspect malaria, the first thing is do a thick blood smear. So they will look at the thick blood smear. If it's negative, meaning it's negative lah. But if it's positive, then they will proceed with thin blood smear to identify what species and also what is the parasite density. Okay, so it's usually done via GIMSA or Leishman stain. So expertise is required, meaning sometimes platelets, cell fragment, impurities can be mistaken for malaria parasite. That's why experience is needed. So ideally, if the fever doesn't resolve and the patient has a risk factor for malaria, you should examine 3 blood film to make sure you don't miss any parasite. Because sometimes, like I said, in people who never had malaria before, they are non-immune. So even low parasite count will cause disease. And then low parasite count meaning it's difficult for you to diagnose through blood film. Okay. So blood film do not have to be taken at times of fever. It's something that I think is a myth. Or you have to wait for the fever, then only you take. It's no, you can take any time. Okay. So semi-immune may have high parasite with relatively few symptoms. As I said before, it's not high enough for them to cause disease. In falciparum malaria, when you have schizon in peripheral blood smear, meaning it may be a severe infection. Basically, usually schizon is actually sequestered, not in the peripheral blood sample. So what is the advantage of doing blood film? You can tell what species the parasite is. You can tell what is the density of the parasite, what is the count, and also you can determine any gametophyte, which is a sexual phase of the parasite. And also you can monitor response to therapy, whether it's the parasite count coming down with treatment. So this is example of blood film. This is a thick blood smear. It tells whether there's a positive or negative. See, this is a positive blood film for thick. And also they will proceed with the thin blood smear. Once you have found the parasite, they will look at thin, look at the species, what species it is. And also they can count the densities, how many % of RBC is infected. Okay. So this is just example of microscopy. These are trophozoite of Plasmodium knowlesi. These are trophozoite of falciparum. Okay. Those who are taking exams probably good or important to know, but for the rest of us, it's probably as far as you know how to do a thick and thin blood film, and to know that thin blood film is required for species identification and parasite count I think is good enough. Okay, so what about rapid diagnostic test? Rapid diagnostic test is basically an antigen capture RDT that use a monoclonal antibody to detect, this is important, histidine-rich protein 2 or Plasmodium falciparum. It requires very minimal training. It's basically a rapid test. It detects any parasite count of more than 100. So main limitation is non-quantitative. It doesn't tell you exactly how many parasites. Sensitivity is reduced when the parasite count is low. And you cannot monitor treatment response because it remain positive for a long time. Even when the parasite is cleared, it still can be positive. And some parasite lack this histidine-rich protein, so therefore they cannot be detected by RDT. Okay, so there are some RDT that actually pan-specific, meaning they detect parasite LDH and parasite aldolase, which are positive in all malaria species. So they are pan-specific. Some tests actually combine the HRP2 with the pan-LDH and pan-aldolase. So they have very good sensitivity of more than 95%, and also they can distinguish whether this is Plasmodium falciparum or other non-falciparum infection. So this is example of RDT optimal or Binax flow, Binax now, which can detect falciparum and pan-Malaria marker, but these RDTs are not optimized for detection of knowlesi. So that's why you have to know the limitation of RDT in our country. Okay. So next is molecular method. How do you diagnose it? Basically molecular method is based on amplification of Plasmodium DNA. So it's more sensitive than microscopy, and it also identify malaria parasite at the species level. So it's useful in mixed infection, especially, for example, it has mixed infection with Vivax and falciparum, for example. So it's good to do the PCR and tells you exactly. But what's the disadvantages? It's not very useful or non-routine in remote area. It's quite difficult, and it take quite long in a remote area for you to get the diagnosis back. Even if you're doing, if you're If you're doing it in a big hospital, it takes about 2 to 6 hours for the result to come back. Whereas for microscopy, it's only take about 30 minutes for experienced person. And also it's high cost, of course. So there's another thing, also a molecular method. We call it loop-mediated isothermal amplification, which is something interesting. It takes shorter period and actually less expensive compared to the nested PCR. Yeah, it's something interesting to know lah. Okay. So the detection limit for the loop-mediated basically LAMP is actually lower, so it's actually more sensitive than the nested PCR. And it actually takes much shorter than nested PCR. It's about 30 to 60 minutes when you get the result, whereas the PCR can take up to 8 hours. Okay, so microscopy is basically the gold standard. Of course, you need the appropriate expertise, and the limit of detection is usually about 200 parasite. RDT is actually not sensitive enough, and it cannot differentiate the species, and you need more than 100 parasite count to detect for it to be positive. Whereas PCR is sensitive and specific, it requires expensive equipment. It takes about 6 hours. Okay. All right. So the next important thing is, how do you manage a confirmed case? So in Malaysia, all confirmed cases basically need admission. Okay, so and once you confirm the diagnosis, you have to start anti-malaria immediately. Okay, if they have severe malaria, or they cannot take orally if they can't swallow any tablet, you have to give parenteral treatment, or in children you can give rectal therapy for 24 to 40 hours. And then once they can take orally, or once they improve, you must follow the treatment with a full 3-day course of artemisinin combination therapy. So also don't forget all the supportive care. They have high fever, they will need antipyretic. If they're vomiting, antiemetic, anticonvulsant for seizure, and also don't forget to monitor for hypoglycemia and judicious use of fluids, oxygen, and some may need blood transfusion for severe anemia. Severe AKI may need hemodialysis. Some severe malaria may need ICU care. So for those unstable patients, they will need daily blood filler to make sure that the parasite density come down with your treatment, and you must make sure there's a cure, meaning you have eliminated all parasites. Okay, and also they will need daily, especially FBC, to monitor for anemia and the platelet counts. So the therapeutic aim is basically to eliminate all parasite, prevent progression of disease, prevent transmission to others, and you want to stop resistance of anti-malaria. So how do you want to stop spread of drug resistance? Basically, you try to administer only to confirmed cases. Okay, so artemisinin combination therapy, most of the anti-malaria are now combination therapy. We don't use monotherapy anymore. Why? Because we want to increase the efficacy and shorten duration of and therapy, and reduce the risk of resistance. And also is appropriate weight-based dosing. It must follow the weight of the patient. Okay, so incorrect approaches, for example, using monotherapy or incomplete dosing, or for example, only give first dose and then never continue the treatment even if it's a confirmed dose. All this will cause anti-malaria resistance. Okay, these are the examples or agents that are used for anti-malaria. So it's very important to know this drug quinolines. Quinolines this is not quinolone. Quinolone is antibiotic. So quinolines, the important drug is quinine, which is a very old drug since 16th century. It comes from the tree of cinchona tree. Quinine tree is used to treat malaria since 16th century. It inhibits erythrocytic stage of parasite, but not the liver stage. But it's already a lot of resistance, especially in our area. Okay, chloroquine is also a important drug, but we are not using it because of the resistance currently, especially in our area. So it's active against erythrocytic stage. Okay, so mefloquine, amiodarquine, piperacquine. Another important one is primaquine, which is active against the hepatic stages of parasite, including the hypnozoid stage. So, as you know, Vivax and Novali, they have hepatic stage, right? So you must give primaquine for them. So it's active against gametocyte, but they have quite poor activity against the erythrocytic stages. So it can cause hemolysis in D6PD patients. So another important one is lumefantrine, which we use in combination in our Reamed. It inhibit the erythrocytic stages. Used in combination with artemether, which is artemether lumefantrine, which is our Reamed. But unfortunately, there has been resistance reported in Central and West Africa and Thailand. It can cross-resistant with mefloquine. So the bioavailability of this drug is increased with fatty meals. That's why when we serve Reamed to our patient, it's important that they take some fatty meals with them. The easiest would be full cream milk. Okay, other agents would be antifolate like proguanil, pyrimethamine. Pyrimethamine is active against our toxo, PCP, but also against parasites. Other agents would be atovaquone, all these. Even doxycycline is actually has anti-malarial activity. So quinine plus tetracycline is actually used for treatment for MDR falciparum in malaria. Even in some areas that they don't have artesunate, they are still using IV quinine for severe malaria, but they combine it with doxycycline. But doxycycline is contraindication in children and pregnant women. So the next important anti-malaria agent is artemisinin and its derivative. This is basically very effective for blood stages of Plasmodium. It rapidly kill, including all the gametocyte. It's basically the fastest fever and parasite clearance. And it's also good because it's very effective against cerebral malaria. So what are the example of artemisinin combination therapy? The one that we use in Malaysia is artemether, lumefantrine. We call Reamed. In some area, they call Coartem. Okay. So these are other artemisinin combination therapy which are highly effective. Okay. So treatment for malaria is basically quite simple. You just have to know whether it's complicated or severe. You just have to know whether this is uncomplicated or severe malaria, and you have to know the species of the malaria. 3 things, okay? So if it's uncomplicated malaria, meaning it doesn't have any features of severe malaria, so you can, and they can take orally, then you can give artemisinin combination therapy, which is Reamed. So Reamed is basically a 3-day treatment with total of 6 doses. Day 1, you give stat, and then you give up to 8 hours, and day 2 and day 3, you give 1 dose BD. And you can give Reamed with in pregnant patient, but make sure they take fatty meal when they actually consume the medication. And why I said you must know whether this what species it is, because it's important to know whether you need to give preventive therapy for relapse or not. For Vivax and Ovali, they can have relapse because they have liver hypnozoid which remain dormant in the liver. So for them, you have to give 14 days course of primaquine. Okay, 0.25 to 0.5 mg per kg for 2 weeks. But if they have G6PD deficiency, you may give 0.75 mg per kg, but just once a week for 8 weeks. But you have to monitor for any primaquine-induced hemolysis. What about if they are pregnant? Of course, if they are pregnant, you can't give primaquine. So you give weekly chemoprophylaxis with 300 milligram chloroquine until delivery. So it's basically you are giving them prophylaxis until they deliver. And then once they deliver it, you have to still give them the 14 days primaquine to actually achieve radical cure. You want to really cure the liver hypnozoid. Okay? Then sometimes you do have mixed malaria infection, which can happen, especially if they have Vivax actually. They may have mixed infection. For example, in Thailand, 8% of patients with acute Vivax malaria also have Plasmodium falciparum infection. So it's actually best detected by PCR, but the treatment is the same. If it's uncomplicated, you can give ACT, okay, artemisinin combination therapy. All right, next we go to severe malaria. So how you actually define any of the following? If they have any of the following, meaning they have severe malaria. All these I've spoken before, yeah, coma, seizure, acidotic, low sugar, severe anemia, AKI, severe jaundice, or pulmonary edema, shock, parasite count of more than 10, but then 10%. But then in plasmodium knowledge, if they have more than 20,000 per microliter is considered hyperparasitemia and they have severe malaria. Okay, so how do you treat? It's easy. It's just IV artesunate, 2.4 milligram per kilogram at 0, 12, and 24 hours. If they have clinically improved, you may switch to oral therapy. But if they haven't improved or they can't take orally, you may give daily artesunate. Okay, but it's important when you convert them to oral therapy, you must give the full cost of the Reamed. Okay. And IV artesunate, you can give it in pregnancy. Okay, so don't forget all the complications of severe malaria. So especially fever, low glucose, anemia, they may need transfusion. Watch for APO. Don't give too much fluid. If they have AKI, they may need dialysis. Yeah, all these things must be monitored and treated accordingly. Okay, I just want to talk about a little bit of the resistance mm, because I think it's important. Okay, so if you see actually quinine, IV quinine ni was used since 1632. But in 1910, which is after 200 years, they already detected there's a resistance to quinine. Chloroquine is another important drug introduced in 1945, but in 1957, they have actually seen cases that are resistant to chloroquine. So in late 1950s, Plasmodium falciparum that's resistant to chloroquine was actually found in Thai-Cambodian border and in Colombia. After that, endemic areas in South America were affected by 1980s and almost all in Asia and Oceania by 1989. And in Africa, the first chloroquine resistant was in 1978 in East Africa. What about P. vivax? So vivax resistant to chloroquine largely concentrate in Papua New Guinea and Irian Jaya, which is in Indonesia, and sporadic reports from elsewhere in Asia and South America. But so far, there's no resistance documented for Plasmodium malaria or Vali. So what are the markers that actually found associated with resistance? So PFCRT polymorphism ni associated with chloroquine resistant. DHFR and DHPS polymorphism associated with sulfadoxine pyrimethamine resistant. And this one, the another thing is PFMDR, which is associated with resistant to certain drug like chloroquine, mefloquine, quinine, and even artemisinin. So these are the geographic distribution of antimalarial drug-resistant Plasmodium falciparum. So you can see the blue one is chloroquine resistant. In our area, of course, there are chloroquine resistance. And the more worrying is the artemisinin resistant. You can see here, So artemisinin resistant, falciparum that's resistant to artemisinin reported in countries of the Greater Mekong sub-region. What is the greatest Mekong sub-region? Yang hijau ni Myanmar, Thailand, Cambodia, Vietnam, Laos, all these South China ni, they have reported artemisinin resistant and it's associated with CAL13, PFK13, So hopefully it doesn't spread to Malaysia so far. So far the delayed plus clearance is not a problem in Malaysia lah. So this is something that we should be aware of lah. Okay. So what actually can the factors that can contribute resistance is basically subtherapeutic dosing, or actually you actually use the antimalarial without indication. Okay. Or these are the things that actually we have to make sure that we don't simply give anti-malaria, which actually will become a problem in future. Okay. All right. So that's about malaria. I just want to share a case that we had. So, 51-year-old TNB worker, he came in with fever for 4 days, headaches, arthralgia, myalgia, and a little bit of shortness of breath. So his HP was 9, white cell was 29, platelet was 31. Dengue combo test was negative. His white cell was 29, but because of the platelets low, dengue was done. Of course, thankfully it was negative. RTK COVID was negative. So a little bit of AKI, a little bit of transaminitis, total bilirubin of 25. This is a chest X-ray, patchy opacities. You can see bilateral lung. So of course, he was treated as septic shock secondary to CAP. So FBP was sent routinely because of anemia, HP of 9. So he was given ceftriaxone. However, in the ward, he was persistently hypotensive. He needed vasopressor, and he was on Ventimas 60% in the ward. So for a few days, he didn't improve. He was persistently hypotensive, and this was his temperature. And after 3 days, the FBP came back, meaning somebody called saying that, hey, we saw malaria parasite on the FBP. And we sent BFMP. It turned out to be Plasmodium knowlesi, and the count was 8,000 asexual. So further history, when we dig, actually, he went to do some work at Pencawang Electric, which is situated in the jungle, forested area. I think it was in Rompin. 1 week before he had fever. So initiated IV artesunate, and within 24 hours he improved. He didn't need any inotrope support. So so this is the case. Actually, is linked to another one. After few days, his friend came to emergency department with fever. So when we asked, when he said he is a contract worker with TNB, when we asked, did you go to that Pencawang with your friend? Yes, they work together. So before the BFMP was sent, the result came back. We already started him on IV artesunate because we already suspect malaria infection. So thankfully the BFMP came back as Plasmodium knowlesi. So these are the example of when we start empirical artesunate when the clinical suspicion is very, very high. Okay, so the learning point will be basically fever with thrombocytopenia, especially if they have visited a jungle or deeply forested area, have malaria as differential diagnosis. All right, that's all from me. Thank you.
Thank you, Dr. Munira. First of all, I would like to apologize for the not being able to share in the initial part because of some technical issue. But thank you for the extensive talk. I think there's some questions. Yeah, the first question in the chat box. What will be the choice of antibiotics for secondary infection prophylaxis?
Secondary infection, I think we have to cover gram-negative because as I said, there are studies saying that gram-negative septicemia can occur, especially in children. So anything that with gram-negative coverage like ceftriaxone, I think would be appropriate. It depends on okay, obviously, whenever you want to start antibiotic, you have to look for the most common source, most common organism depending on the site of infection. So, for example, if it's intra-abdominal, you need to have gram-negative and anaerobic coverage, for example. But if you can't find, I think as long as you cover the gram-negative organism, it should be fine. It doesn't have to be too broad spectrum, I think. Dr. Cheng, if you have any other answer to that,
Yeah, generally, if patient is not too ill, remember to get a blood culture as well. Generally, I'm not a fan of ceftriaxone. I usually use augmentin or lunasin to start with if the patient is not too ill. Thank you. Yeah, so the second question is I think pertaining to the case, why empirical IV artesunate if the patient is not severe malaria?
No, actually the patient had severe malaria because he was in shock. Blood pressure was low on vasopressor. That's why he was given artesunate.
I think it was the second case, the friend of the other patient. Good. I think that's what they meant, I suppose. But
No,
anyway, yeah.
that patient was inotropic support.
All right, right. Okay.
Persistently hypotensive.
All right.
Mm.
Yeah. The the third question I think is were we treating severe malaria when using artesunate, were you combined with doxycycline?
No, actually, the guideline that we have in the Malaysia guideline is actually a bit outdated. I think if you read the WHO guideline, the latest one in 2021, if I'm not mistaken, um, basically you don't combine with doxycycline anymore, unless you're using IV quinine. Yes, IV quinine you combine it with doxycycline, but otherwise, if it's Reamed or artesunate, you don't need doxycycline anymore. But remember, for Vivax and Novali, they need primaquine for the liver stage.
Yeah, thanks. Then for preventing relapse in Vivax and Ovale, the dose of primaquine is 0.25 to 0.5 mg per kg per day for 2 weeks. Is there a certain strain we choose 0.25 per kg, a certain strain we choose higher, and which is 0.5 mg per kg per day?
I don't think it depends on the strain lah. For example, um, maximum 45. So you can give any range of 0.25 to 0.5. It doesn't depend on which strain, I think. As long as it's Vivax or Vali, the dose should be around that. It's only in G6PD that you give higher dose, but just once a week. Yeah.
All right, thank you. The next question is the army use doxycycline prophylaxis acceptable, 100 mg OD for prolonged period of time?
I think chemoprophylaxis um, with doxycycline is one of the drug for chemoprophylaxis lah. So if they're going to the deeply forested area for a long time, yes, I think it's not. I mean, it's not something wrong. Of course, they have risk for malaria, and doxy is one of the anti-malarial prophylaxis drug lah. So if they're going for a long period of time and with significant exposure, yes, I think.
I think the problem with the army also usually their compliance is very poor. I don't think they will take it properly.
Mm.
Yeah. So I think that will be another thing that you want to advise them. So the other question is, what is your thought if empirically, for any role empirical treatment, if there is despite the ×3 BFMP negative, but there is a still high clinical suspicion in a patient from a suspected area. Any role of empirical and malaria treatment despite negative BFMP ×3?
I think it depends. I think you have to keep sending the BFMP until you can see. And as I said before, if the clinical suspicion is too high, they may be role, but then generally we avoid giving empirical because you don't want resistant to anti-malaria because it's very precious drugs. You don't want to cause. You don't want to make it a habit that is actually quite bad. Has bad consequences lah. So for me, you keep sending BFMP and also you keep finding other source of sepsis or infection. But I'm not sure in highly endemic area like in Sabah how is the practice. But in West Malaysia, we usually keep sending until it's positive. Unless like in the cases that I had the friend that had malaria and then they worked together and then the friend came a week later. So this one is very suspicious. So that one I give empirical, but it turned out to be a malaria infection lah. But I think empirical without a confirmation is I don't think it's a good practice lah. Mm.
Yeah, agreed. I think if you have clinical suspicion and your BFMP is negative, I think you can actually send a full blood picture also. Sometimes you pick up malaria in full blood picture. Yeah, I think I probably will go with the last question. What is your view on the use of lateral flow test if the BFMP is negative, such as case return from Papua New Guinea?
Oh, you mean the rapid diagnostic test, is it? Of course, the rapid.
Yeah, I think that's what the Yeah,
Yeah,
that's
of
what
course, the rapid,
probably they meant. Yeah.
yeah, lateral flow is rapid test. Yeah. So the rapid diagnostic test, we have to remember that um, it's more. Of course, some tests are pen specific. It can detect a lot of malaria parasite, but it has a bit of limitation in knowledge. Knowledge, you have to remember, if RDT is probably not sensitive enough to detect our parasite. Okay, because knowledge is common in our region. So they develop the RDT based on mainly Plasmodium falciparum. Uh, but if your RDT is negative, it doesn't mean the patient doesn't have malaria. That's the thing you have to be careful lah.
Okay, I think it's about time. Probably the other questions maybe Dr. Munira can answer in the chat box, or the organizer can send the questions to the Dr. Munira so that we can get feedback to the audience. I pass it back to the organizer. Thank you again, Dr. Munira, for the
Alright.
good talk.
Thank you, Dr. Cheng.
Thank you, Dr. Cheng and Dr. Munira, for this insightful talk. We will see next week for another new topic in malaria, another new topic for ID. Thank you.